score on the sheet I sent you in your email. That's the old score. The new scores with the +3 should reflect on Praxis school. If it isn't, let me know. I'll double check it. I just went through, and they should have the current score on there. And also, please remind me at the end of class, just in case I forget, guys. I have had some of you guys request to know what the positions are on the practice images I sent you. Don't let me forget. At the end of class, I can go through those real quick and make sure you have those positions labeled. Okay, let me get everything pulled up here. We're going to get rolling along. All right, when last we left off, we finished up on the ankle, and we're now about to move on to the lower leg, also known as the tibia and fibula. One thing that's great about this section of the lower limb is there's only 2 positions we got to learn for this one. So I love tib fib. Easy to remember and only 2 positions. That's the best one of all. I love it. So all we're going to do for tib fibs is literally an AP or lateral. No obliques, no PAs. It only ever is AP and lateral. Now, in some facilities, there does exist an oblique tib fib. That's more so dedicated to pediatrics if they suspect an abuse case. That's the only time I've ever seen an oblique tib fib ordered. But as far as what you officially learn, that actually does not exist. That's more of a made-up procedure specifically for pediatric facilities. You only need to know that there's an AP and lateral tib fib that we do for that lower leg. Now, one thing you'll notice here on some of these pictures, they do have the leg straight out with the cassettes lengthwise. One thing I definitely recommend when you're doing your lower leg, I'm not sure if you guys learned this in lab, but if you put the leg on the diagonal axis, in other words, if this was I would put the leg along the diagonal part of the cassette like this, you have more of a chance of fitting that all on one film. It gives you a little more space to work with. So while we always want you guys to have your cassettes oriented either landscape or crosswise, for tib fibs in particular, you have that option of rotating that cassette on the diagonal axis. And if you line your leg up with those diagonal corners, you have a better chance, like I said, of getting both the knee joint and ankle joint on one film. Because it is part of our evaluation criteria for the lower leg tib fib is that we have to have both joints present. Otherwise, we have to do what we call an upper and a lower. Like we have to do an upper tib fib, lower tib fib. And a lot of people have very long legs. I have very long legs. I wouldn't fit on a lengthwise cassette like that. I would need to be put on the diagonal axis. So I definitely recommend when you do a tib fib x-ray for the APs and laterals, put the leg diagonally on the cassette, and you'll have a more of a chance of getting it all on one film, which will save you some time and effort and dose for your patients. To start with our AP, we want the patient to be supine or seated, much like everything we've reviewed so far. We want that leg straight out, completely extended. And one thing to keep in mind, because we are still visualizing that ankle joint, guess what we have to do? Dorsiflex the foot. Seeing a kind of a pattern here, right? Anytime that ankle is in that picture, no matter what kind of x-ray we're doing, we want that foot dorsiflex because they evaluate that ankle very closely. So for an AP tib fib, AP leg, we are dorsiflexing the foot. 40-inch SID. I will say for the lower leg tib fib, the official SID is 40. We'll see some techs bring that SID up a little bit. And the reason for that is because the leg is so long and sometimes doesn't fit very well, when we bring that SID up, it's going to demagnify, lessen the magnification of the lower leg, and gives it more of a chance of fitting on that one film. So it's another one of those exams where that SID is a little bit variable, but the official SID you need to know for it is still going to be 40 inches. But do keep in mind, you'll see some techs raise that SID, and the reason they're doing that is to make the leg a little bit less magnified in the hopes it's going to fit on one 14 by 17 cassette. Now for our CR, it is going to be a perpendicular beam, no angulation. That CR is going to enter at the mid shaft of the tib fib. That's halfway between the ankle joint and the knee joint, essentially. 14 by 17 portrait or diagonal cassette, like I just said. You can put it diagonal or portrait view. And we're going to collimate sharply to that part because the tib fib is quite thin. We want to make sure we have that nice tight collimation horizontally. Leave that collimation open longitudinally. Leave it open on the vertical axis because you do need to see that knee joint and ankle joint included. Tabletop always. You will not do this in the table. This will be tabletop only. And of course, gonadal shielding, as with everything that we've talked about thus far. Now, as far as our evaluation criteria goes, we do want that entire tibia and fibula demonstrated. One thing that a lot of techs make a mistake on is they'll barely cut off that knee or ankle joint and they'll still send it in. We must see both those joints fully demonstrated. Knee and ankle joints must be in clear view. And where techs make the most mistakes I've seen is they tend to cut off the joint right here at the distal end of the tibia, the distal end of the fibula connecting to the talus. They'll cut that off, but we do need to see that entire Mortise joint, entire ankle joint, and that entire knee joint demonstrated. This is why, once again, I recommend if you do these x-rays, you put the leg diagonally on the cassette, you have a much higher chance of getting that all in one x-ray. But if one of those joints are cut off, you must do an extra film to include that joint. For example, if I did this AP and I'm missing the ankle joint, I need to go back in there and do a dedicated ankle joint film to include that on that tib fib series because they must evaluate both of those joint spaces. We also want partial superimposition of the fibula and tibia at the proximal and distal ends. That tells us that we're in a true AP. And of course, our tight collimation horizontally with our optimal exposure factors. This is going to be our evaluation criteria on our AP leg, also called the AP tibia fibula. Now, for the lateral leg, we're always going to do a mediolateral, by the way. There will never be a lateral-medial. It's always mediolateral, which means that beam enters the medial side of the leg, exits the lateral side of the leg. And this position here is demonstrating what I'm talking about. When you're doing your tib fibs, it's much, much more effective if you put that leg diagonally on that cassette, whether you're doing AP or lateral. And once again, the purpose of that is because the leg's quite long, it's going to give you a much better chance of getting that entire leg on one film. So we still have our patient supine seat on the table. We're going to extend that leg out, dorsiflex the foot. Remember, we're showing that ankle joint, so we're dorsiflexing the foot. And the leg and foot are rotated medially approximately 45 degrees. And the purpose of that is to put that leg into a true lateral position. 40-inch SID, but once again, that's slightly variable. You'll see some techs raise that SID for the lower legs particularly, to make sure it all fits on one film. Because as you raise that SID, it's going to shrink the part down a little bit. It's a perpendicular central ray still at the midpoint of the tib fib between the knee and ankle joints, midway between the malleoli. Actually, I should not say that. I need to update that. Oh, hold on. Don't write that down. The CR should not be between the malleoli. It should be at the mid shaft of the tib fib. CR mid shaft of tib fib. This is wrong too. I apologize, guys. This got mixed up with another position. This should be a perpendicular central ray at the mid shaft of the tib fib, and the cassette size should be a 14 by 17 lengthwise or diagonal.
Repeat where you said it goes for the CR?
CR is going to be mid shaft of the tibia and fibula, halfway between the ankle and knee joints. So we are going to collimate very tightly once again. There'll be a horizontal collimation to make sure we have that nice thin view of that tibia and fibula. And we're still going to be tabletop on all these x-rays. We would not do this in the table. This would be a tabletop only exam. And that's what we see right here. That central ray is at that midpoint, halfway between the knee joint and the ankle joint, mid shaft of the tibia and fibula. Now, what is our evaluation criteria? It's very similar to what we just talked about on the AP. We still want to see that entire tibia and fibula demonstrated, and we must include both of those joints. That's talking about that knee joint and that ankle joint. Once again, if we cut one of those joints off, we've got to do a dedicated film demonstrating that actual joint space to include on that tibia fibula series. Now, in the lateral position, we do want the proximal head of the fibula to be superimposed by the tibia. And we want the distal fibula to be superimposed over the posterior half of the tibia. That tells us we're in a true lateral position. Very important point to remember on that. While you're writing that down, does anyone see anything peculiar on this X-ray?
There's a hairline fracture in it.
There is, right there. Very good. It's on a pediatric leg, by the way. You see the growth plates? Very common fracture that we see on abuse cases, right there. A lot of abuse cases come in. It's a very common fracture. Now, this person did the technique I was talking about, where they put the leg diagonally on the film. I really do highly recommend that on your tib-fib films. It's going to save you a lot of headache, and including both those joints, because it gives you a little bit more room to work with on that cassette.
You too. What you want?
Okay, so we're going to move on to the knees. We've got a few more positions in the knees. Then we're going to wrap this thing up with the patella. So let's move on to our knee positions. So for our knees, our routine exams are going to be AP, obliques plural, because we have two different types of obliques. Sometimes both are ordered, sometimes one or the other is ordered. That's going to be a medial or lateral oblique. And then we have our lateral view of the knee by itself. We also have some special views, which we'll go over as well.
Don't jump off.
This is one of those special views right here. This is bilateral standing knees. You'll see this done at a lot of clinics that you guys visit. They do them a lot like this in the clinics. It's a specialized view. But the regular routine is going to call for one knee. It's going to be an AP, medial or lateral oblique, and a true lateral knee. Talking about our AP knee, we are going to have the patient laying flat on their back in the supine position. Our CR is going to be a 1/2 inch distal to the apex of the patella. Therefore, it's very important when you do your AP knees that you palpate the top of the knee. Actually find where the patella is, where the apex is the inferior portion of the patella where it comes to a point. When you find that apex of the patella, you want to go 1/2 inch below that, and that will be where your central ray is. Essentially, it's basically right in that exact point of where that knee joint is located, very close to those tibial plateaus on the tibia. So you can kind of palpate on your patient. You can even palpate on yourself. When you find the apex of your knee, there's a really soft area there where your knee joint's located. It's essentially where you want to put that central ray for your AP knees. Oh, my chart's missing there. So one thing you'll learn, guys, is depending on the size of the knee, sometimes people will add an angle to an AP knee. Sometimes they'll do a perpendicular beam. Me personally, I always add an angle on my knees. I'll do a 5-degree cephalic angle, but make note that it's not required. For larger knees, you would add an angle. For regular sized knees, it suggests you do a perpendicular beam. Me personally, I always add the degrees of the angulation because I have found it makes better x-rays for AP knees. But as far as what your book says, perpendicular beam is the most common way to do it for most average knees. You would add an angulation if it's a very large knee. That'd be about a 5 to 10 degree angulation towards the head, cephalic. Evaluation criteria. We, of course, what are we looking at? We're looking at the knee, looking at the knee joint. We must have that femorotibial joint space completely open, which we do see right there on that x-ray. That knee joint must be centered to the film and collimation film. We also want to see the articular facets profile. What do I mean by articular facets? If you remember, that's an alternative way to say the tibial plateaus right here. We want them nicely in profile, which we do see in this x-ray. Our tight collimation, always vital, using our optimal exposure factors, as goes with everything we talked about. gonadal shielding. And one thing, because I didn't have the chart here, I apologize. On your knee x-rays, it's recommended. Now, you'll remember on all of our other lower extremities, we've done tabletop. For knees, it's recommended you do them in the actual table bucky. Why? Because the knee's a lot thicker. It's a larger piece of anatomy, and you got to clean some of that scatter up. So it's recommended on knees that you do it in the table bucky, even though you are allowed to do that tabletop if you do choose. But definitely recommended to go ahead and do those knees in the table bucky. Clean up some of that scatter radiation because you are dealing with a much thicker part in comparison to the rest of that knee. I'm sorry, to the rest of that lower leg. So tib fib down to the toes, it's recommended to be tabletop. When you get to the knees, it is recommended you use the table bucky. So that grid in there. So let's talk about our medial oblique. Medial oblique is a medial rotation of the knee. So as far as the centering goes, our centering is in the exact same spot as the AP we just talked about. We're going to put that CR a half an inch inferior below that distal apex of that patella. So you're going to find that patella, bring it down half an inch. But if you've already found that for your AP, keep in mind your centering does not change. You can keep it in the exact same spot. The only thing you need to do positioning-wise is rotate that knee medially 45 degrees. And that is a 45-degree only oblique rotation. No range there, 45 degrees only for those medial oblique knees. We're still at a 40-inch SID. It's still recommended that you do this in the actual table bucky instead of tabletop. And the patient will, of course, be supine, lying on their back, and we'll be using that gonadal shielding just like everything else we've talked about. So not difficult to do. You find your AP knee centering, you get it all set up, you take your x-ray, you go to your medial oblique, you're simply just going to rotate that knee 45 degrees, which is not an extreme rotation. You're just going to rotate that knee a little bit medially. Your centering's in the exact same spot. You're in the table bucky, take your medial oblique. If you have that lateral oblique, it's going to be the complete opposite of that. We're going to rotate the knee laterally 45 degrees, which we'll look at that one next. And there is a way to tell a difference on these when we're looking at x-rays, and we'll show you that coming up. They do have a distinct look on the actual x-ray films. So people do tend to mix up these medial versus lateral obliques, but it's actually quite easy to tell a difference. And I'll show you how in just a second here. So for the lateral oblique, like I said, that's the complete opposite of what we just talked about. We're simply just rotating laterally, and that should say lateral. Man, sorry about these typos today, guys. Man, I should not have jumped into class so early today. I need to review this before I did the lecture. This should say a lateral rotation, 45 degrees. So we're going the opposite direction in that medial oblique. Still a 45-degree rotation, by the way, and our centering's still exactly the same, where we're putting that CR half an inch distal to the apex of that patella. So medial and lateral, almost exactly the same. We're just going different directions. Medial rotation versus lateral rotation. And these are all perpendicular beams, by the way. No angulation still. Now here we can see those x-rays side by side. Now I said there's an easy way to tell the difference between a lateral versus medial oblique on an x-ray because it's something you do need to know and something you need to look at. So we have all this evaluation criteria we're going to go over in a second here, but there's a key way to tell the difference between a lateral versus medial oblique knee. It's all in the patella location. Look at the patella on those two x-rays. Now this x-ray on the left is a medial rotation. How do I know that? If you look where the patella is, it's closer to the tibia. And I know based on my anatomy, the tibia is more medial. If the patella is on the side of the tibia, it's always a medial rotation. Now look on the reverse side here. This is a lateral oblique. How do I know that? Because the patella has shifted location. The patella is now closer to the side of the fibula. And that's the direct way, the easiest way to tell the difference between both those obliques. Medial rotation, the patella will be on the side of the tibia. Lateral rotation, the patella will be on the side of the fibula. Fibula is always on the lateral side of the leg. Tibia is always on the medial side of the leg. That's the easiest way to tell the difference on those. And make sure you can tell the difference on those films. Make sure you look at a left leg versus right leg because those sides do shift and change. Don't let that mix you up. But look at where that patella is located, and you'll be able to tell the difference of what those rotations are in comparison every single time. Now, for our evaluation criteria, they do share an evaluation criteria. What are we looking for on our oblique knees? We're looking for the proximal tibiofibular joint to be open, and we want the fibula to be superimposed over the mid-tibia. Now, this does need to have a little bit of notes added to it. Hang on a second. This one right here, guys, where the proximal tibiofibular joint is open, this is talking about the medial oblique. This one right here, where the fibula is superimposed over the mid-tibia, this is talking about the lateral oblique. Two distinct evaluation criteria to tell those apart. That's another thing you can look for, by the way, if the patella method does not work for you. Let's look at this first evaluation criteria. It says the proximal tibiofibular joint is open. If I look at these x-rays side by side, where's my proximal tibiofibular joint? Well, it's right here. Which one's open? This x-ray on the left. So that tells me that's a medial oblique. Let's look at this other evaluation criteria. It says the fibula must be superimposed over the mid-tibia. Well, that's talking about this right here. Fibula is superimposed on top of that tibia. So that tells me that's a lateral oblique. Medial versus lateral. So you can look at the placement of the patella, but you can also look at the open joints versus that fibula being superimposed on that tibia. So two ways to tell the difference between those two x-rays. Make sure you can tell the difference between those two types of x-rays. You're going to see that pop up on you. I'll guarantee you'll have a question on that. Know the difference. All right, so for our lateral knees, so much like with the tib fib, we are always going to do a mediolateral oblique. We would not do a lateral medial oblique at any point in time. It's always mediolateral. And once again, what's that mean? That means my central ray enters the medial side of the knee, exits the lateral side of the knee. So I need to make sure my patient is in that position. Now, one thing to make sure that we always do, this is very important on our knees. Let me go through the other criteria first, and we'll come back to the CR angulation because that's very important on these lateral knees. AP and the obliques, you can do a perpendicular beam, but for the lateral, we must have that CR angulation. So we're still going to be lying, patient on the table. They're going to be in a lateral position, making sure that knee's in a nice true lateral. We want to make sure that knee is touching that table properly. On that point, this is going to be an exam, once again, done inside the actual table bucky, because with knees, it's much thicker. We got to clean that scatter up. We want this actually in that table bucky. We're 40-inch SID. We're having a tight collimation. And our central ray is going to be 1 inch distal to the medial epicondyle. How do I find the epicondyle? Palpate that on the side of the patient's knee right here. You can palpate that on yourself. Epicondyles are a prominent little bump found on your femur, real close to where your patella is. If you bring your fingers over your patella and then bring your finger to the sides of your leg on your femur, that's your epicondyle. You want to be 1 inch below that. It's essentially going to be the same spot as those AP and obliques, by the way. We're just looking at it from a lateral view. Now, let me come back to this angulation. It's very essential when we do a lateral knee that we put a CR angulation 5 to 7 degrees, a little range there, 5 to 7 degrees cephalic. It's a very important point because the way the condyles and epicondyles lie on the femur in a lateral position, I add that angulation to better superimpose the condyles and epicondyles of the femur, because we must have those epicondyles and condyles superimposed completely for a proper true lateral knee. If I do not add my angulation, I have more of a chance of those being obliqued and separated. We want them superimposed. We achieve that superimposition by adding that 5 to 7 degrees cephalic angle on that tube. Do not forget that angulation on those laterals. Now, there's something else I definitely recommend you guys do on your lateral knees. I'm not sure if you guys learned to do your laterals like this in lab, but one thing that I learned that works great is if you take this opposite leg, you see this leg right here, guys? If you bring this leg over the knee you're x-raying, like to the front of the patient, I have found that gives you almost perfect lateral knees every single time. It puts the patient's knee in a more true lateral. Not required, but definitely something I recommend based on my experience. You bring this knee over the knee you're x-raying, completely over. Works like a charm. Don't have to do it, but definitely something to keep in mind. It's one of those little tricks I've learned that works great. Your book's not going to talk about that, but that would be one of my special little cheat codes, as I say sometimes, to get better lateral knees. If I ever get a chance to show you guys in person, I'll show you that in person and make more sense if I could actually show it to you. But bringing that opposite knee over the affected knee works wonders in getting those lateral knees superimposed on those condyles. And that's what we want to see right there. This demonstrates perfect superimposition of the condyles and epicondyles on the femur. This is what I want to see. How do I achieve that? Once again, that's adding that cephalic angle we just talked about, 5 to 7 degrees. Cephalic angle is going to help me better superimpose the condyles and epicondyles. And that's part of our evaluation criteria. We must have the femoral condyles completely superimposed. We don't want to see those condyles separated. That tells you that the knee is obliqued. For a true lateral, they must be superimposed. We also want that patella in profile, which we have a nice, beautiful lateral patella demonstrated right here. It's exactly what we want to see. That tells us, once again, that we have a true lateral going on with that knee. And we need to see the patellofemoral joint completely open, which we see right here. If this joint space is not open, it's another indication that I did not put the knee in a true lateral. It's closed. We did not position that knee properly. So we need to see condyles superimposed, patella in profile, and the patellofemoral joint space completely open for a proper true lateral knee. And once again, that little technique I just told you about, bringing that opposite leg over, is going to help you achieve those results much better. Much, much better. Works like a charm. And that's going to be our routine positions for the knee. The other knee projections we're going to talk about here in a few minutes are going to be what we call special projections. That would be specially ordered projections. And that's what we're going to talk about next. So some of the special projections we're going to talk about are our weight-bearing knees. We have also what's called an intercondylar fossa view, which is a specialized view to better visualize that intercondylar fossa that we find in the mid portion of the knee. And then we have some AP axial views we're going to go over as well. It's actually been shortened a little bit. Some of the positions have become so irrelevant, we were able to delete some of the positions. So this is actually a revised version of the positions that you need to know as far as the registry is concerned. Because a lot of these special predictions of the knee are being phased out more and more because we just don't do them anymore. So the first one we're going to talk about is our AP weight-bearing knees. Now this is ordered mostly at clinics. This is a bilateral knee exam. We're going to have both knees side by side, both x-rayed at the same time. That way they can do a comparison view of both those knees. Like I said, this is what you're going to see when you go out to the clinics. They do these AP weight-bearing knees quite a bit. Now the patient will be standing. If you remember the keyword weight-bearing, when you hear that word weight-bearing, that's default for my patient standing up. Putting weight on those knees, check the integrity of those knee joints. For where my central ray enters, my central ray is a perpendicular beam directly in between the midpoint of both patellas, which we see right here. Here's the patient's patellas. We are directly in between both those knees at the level of those patellas. And we're going to make sure we open that collimation up enough horizontally that I'm including both those knees, but make sure I'm collimating down vertically to only those knee joints. And once again, this is done primarily to do a comparison view of both those knees side by side. A lot of doctors love knees this way. That way they can really make a better analysis comparing both those knees next to each other. They also like to do their patella views side by side with that as well, which we'll see as we move on a little bit more here forward. This would be our AP weight-bearing knees. It's going to be a 40-inch SID, by the way, using the wall bucky. Key point there, we're using the wall bucky because we are standing up. We could not do this on the table. This would have to be wall bucky. Of course, no angulation. This would be on a 10 by 12 cassette. 10 by 12 cassette, typically. By the way, I didn't mention that on the other knee views. The majority of your knee x-rays are going to be on 10 by 12 cassettes lengthwise. If you want to write that down, 10 by 12 lengthwise cassettes for your knee x-rays. But for this weight bearing, we would put that cassette crosswise because we are doing a side-by-side comparison. 10 by 12 crosswise. And that's what they're going to look like right there. You could use a 14 by 17, yes, if the patient has very large legs. But the recommendation is if they fit on that 10 by 12 crosswise, go ahead and opt for that. It's going to give you a better quality film. But yes, you do have that option if they just have very large legs, which obviously that does happen with some patients. So definitely yes. So there we have it. We have our weight-bearing knees side by side. And most of the time, you don't see it on this x-ray here, but most of the time, techs will go ahead and put a marker on there that does say weight-bearing. But your biggest clue that you're looking at a weight-bearing knee is what? We have two knees side by side. That's the only time you're going to see that. So if you see two knees side by side, even if the marker's missing, that's a weight-bearing knee every time. That's the only time they would actually do that kind of comparison view, weight-bearing knees. So what do we want to see? Well, of course, we're looking at the knee joints. That's why we're doing a weight-bearing knee specifically to look at the integrity of those knee joints. Therefore, we need those knee joints centered to that film and collimation film. I'm sorry, collimation field. We want zero rotation of the knees, and we want those joint spaces to be nicely open. If the patient's standing straight up with their knees against that wall bucky, you have that perpendicular central ray. If there's no rotation of the knees, those joint spaces will be open, unless there's just severe degradation of the joints due to like arthritis and things going on with the patient. This is just showing you the articular facets, also called the tibial plateau, and that intercondylar fossa right there in the middle. Right there in the middle. This would be our weight-bearing AP special view, never routine. This is a specialized view, even though they do it almost every time at the clinics, which you'll see. Now, this is another specialized view right here. In fact, all the rest of these we're talking about are specialized views. We're going to go through a few of these positions here, specifically the Camp-Coventry method and the Holmblad method. Now, keep in mind, moving forward to these specialized views, we're not going into extreme detail on these knee views. You need to know what they are and what they look at, but not so much all that extreme detail we went through on all the other positions, like, cassette size, SID, angulation, all those kind of things. More so focus on what these are looking at. So what do I mean by that? When you see the word Camp-Coventry method, when you see the word Holmblad method, one thing that needs to default in your mind is those are intercondylar fossa views of the knee. That's specifically positioning that knee to stretch out the intercondylar fossa and give us a better visualization of it. That's the main points I want you to remember on those two projections right there. Camp-Coventry and Holmblad are specifically done to stretch out the intercondylar fossa and give us a better visualization of it overall. Same with that special AP axial view as well. We'll hit that one briefly towards the end of these projections here.
What did you say that again? What it was for?
Sorry, say it again.
What did you say those two methods were for? To visualize what?
So Camp-Coventry and Holmblad and also AP axial are done specifically to look at the intercondylar fossa.
Oh, okay.
Position the leg. No problem. We position that leg accordingly to actually stretch out that intercondylar fossa and give us a better visualization of it. So the first one we're going to talk about is the Camp-Coventry method. This is a position where the patient is prone and they're flexing their leg to a certain degree. Specifically, they're flexing that leg at a 40 to 50 degree angle. CR is going to be perpendicular to that 40 to 50 degree angulation of the leg. And the CR is going to be specifically centered on the popliteal crease. Main point, once again here, guys, you see a lot of info there for these special projections here that I'm going over. The main point I want you to focus on, I'm doing Camp-Coventry to visualize the intercondylar fossa. Big star on that info. It's the main thing I want you to remember there. I am doing this to look at the intercondylar fossa. If I see a picture of that, I need to know that's Camp-Coventry, but I also need to know I'm looking at that intercondylar fossa specifically. Same with the Holmblad we're about to hit here in a second as well. These are becoming more and more obsolete. They do not do these very often anymore, but I think I've done this once in my career, intercondylar fossa, if I recall correctly. Now, what's my evaluation criteria for a Camp-Coventry intercondylar fossa view? I want the intercondylar fossa in profile. I want the articular facets and intercondylar eminence well visualized. I want no rotation, but the main thing I'm looking for, once again, look at this, guys. Here's the main thing we're looking for. You see that intercondylar fossa nicely demonstrated. That's this right here. Look how prominent that opening is. That's why I do Camp-Coventry. That's why I do Holmblad. To specifically open up that intercondylar fossa, stretch it out, and give us a better visualization of that piece of anatomy specifically. So here's the thing too, guys. Let's say I threw an x-ray that looked like this on your test, and I was asking you, what's the view? So one thing to write down is, when we're talking about Holmblad versus Camp-Coventry, they're very hard to distinguish between on an x-ray. So what I would expect you to write, if I showed you an x-ray that looked like this, where you see that intercondylar fossa very prominent, what I would expect you to write is intercondylar fossa view. So while we have the methods, if you'll simply tell me that's an intercondylar fossa view, that's all I need. You can write Camp-Coventry or Holmblad, it'd still be accepted. I wouldn't count that wrong, but intercondylar fossa view would also be an accepted way of expressing that. I'd accept that as an answer as well. And this is that other method right here I just talked about. This is the Holmblad method. It's just an alternative way of doing Camp-Coventry. Still, why are we doing this? To look at the intercondylar fossa stretched out and better visualized on my x-ray. Obviously, this would not be an ideal position to put a patient in. I've never seen it done this way, because if you can imagine, if a patient has knee pain, the last thing you want to do is put them on their knees. Rocket science, right? My knees hurt. I wouldn't want to put them on their knees, but it is a method we can get a better view of the intercondylar fossa. Basically, patient is leaning forward with the knees and legs at a 20 to 30 degree angle. We're using a perpendicular central ray right on the back of the knee at the popliteal crease. What's the popliteal crease? That's the area right behind your knee where the knee actually creases. If you imagine my elbow is the knee, it's the crease right here. Just imagine that's the knee. That's the popliteal crease. Once again, main point here, guys. Why is this done? Intercondylar fossa view. Stretches out the intercondylar fossa. It's a specialized view for that specific anatomy. Even though this says routine here, it's referring to the routine that's done for that view. Do make note, these are still considered specialized views that would be specifically ordered by a radiologist or doctor if they're wanting to better visualize that intercondylar fossa. It would not be what we call routine knee views. So my suggestion is don't spend a lot of time breaking your brain over these specialized views. Remember that main point. These are done for intercondylar fossa. The reason I'm repeating that over and over again, because I get the question every year, oh my God, these special views, these Holmblads and Camp-Coventrys, do I need to know all these little small parts? No, know why it's done, be able to see the picture, and be able to recognize what it is as well. So I might have a picture like this of the position. Yes, I'd expect you to tell me it's a Holmblad method based on the picture. As far as the x-ray, as long as you tell me Camp-Coventry, Holmblad, or intercondylar fossa, that's okay. Why do we do the exam? We're looking at the intercondylar fossa. That's the 3 main points there to focus on. And this is just showing you another way you can do that Holmblad. If they can't get up on the table, we can also do it with the patient on the chair. We can also do it on the wheelchair. But once again, this is just crazy to me. I'm not trying to say that I'm like a rocket scientist here, but my mind's saying if my patient's in knee pain, I don't want to put them in that position. That'd just be stupid. I'm just saying. Therefore, I've never seen this method ever performed. I've done the Camp-Coventry method we just looked at. I've never seen it done this way before because a patient that's in knee pain is not going to get in that position for you. But if they're able to, that would be alternative ways to achieve the same results. Table, chair, wheelchair. Obviously, free cassette exam would be accepted on that, even though it would not be ideal as far as giving you a quality x-ray. And then, of course, the AP axial. This is the last specialized view. Same thing, by the way. This is the third way that we can achieve that intercondylar fossa view. AP axial view, we're going to actually flex the knee 40 to 45 degrees. Our central ray is going to be the exact same way as an AP knee. We're putting it 1/2 inch distal to the apex of the patella. And our CR is perpendicular to the angulation of that lower leg. We do this once again, stretch out the intercondylar fossa, gives a better visualization of it as a whole. It just be called simply the AP axial intercondylar fossa x-ray. And really all 3 of those views, the x-rays look almost identical. Main thing to look at is that stretched out intercondylar fossa, which is why I say the easiest way to remember it is just label it as an intercondylar fossa view. That would be acceptable to label it as such. Okay, and now we are about to move on to our last positions of the chapter. That's going to be the patella specifically. Most importantly, the one we're going to focus a lot on is the set gas method. That's the one you guys learned in lab. That's also the most commonly done. But we also have what's called a regular PA and lateral position of the patella, even though most of the time, the way patella views are done in hospital and clinic is they're usually going to order a normal knee x-ray series. They're going to include that set gas patella with their routine. So a little bit of difference from what's actually listed there because set gas is listed as a special projection. Most facilities are going to include that patellar view with their knee series because the patella is a very commonly fractured bone in the knees. So before I go into these, let's take a quick break, guys. I need to go get me some more water. Let's take 5 minutes. We will come back at 10:15 and we'll continue and finish up our chapter. 10:15. All right, guys, let's get back on here. We're going to wrap this up today. Not much further to go here. All right, so when we're talking about the patella, so the routine views for the patella are going to be a regular PA and a lateral patella. Now, even though you see these listed as routine views, I've almost never in my entire career seen a PA or lateral patella actually ordered. And why is that? Well, most of the time, they're going to opt just for a regular knee x-ray. And also, they're going to throw that set gas view in there, or the sunrise view, as the actual patellar view. So it's kind of wonky. Even though we have a routine PA and lateral, and the set gas sunrise is considered a special view, you're more often going to see that set gas view thrown in with a regular knee series as part of the routine. Now, that's not confusing at all, right? Little wonky. But set gas view is considered a special view, even though you're going to see it most often paired up with a regular knee series. So don't let that throw you off. As far as the knee routines go, we're going to start with the PA. Now, one reason I can tell you right now why they don't order this often is think about it for a second. Look at the position of that leg. If your patella is hurting or fractured, the last thing you want to do is put your leg in that position right there, which is why, in my opinion, they're going to most often just opt for a regular knee x-ray because you can see the patella quite well in knee x-ray as well. It's very similar looking to a PA patella, as a matter of fact. But if we were asked to do a PA patella, we're going to put our patient prone with the kneecap obviously touching the table. This is done in the table, by the way, on an 8x10 cassette with a perpendicular central ray, no angulation. Our CR is going to enter directly into the mid-patellar area, or also called the popliteal crease. That's simply this area, once again, where if I was to bend the knee, the actual crease that's formed by the knee coming together, that knee joint, that's where I'm going to put my central ray. It's called that popliteal crease. That will be a perpendicular central ray collimated down to an 8x10 cassette, even smaller than that because we are only interested in the patella itself on this x-ray. We're not interested in the knee. We're only focusing on the patella. And that's what it's going to look like right there. Almost looks exactly like a knee. Only difference is we're a little bit higher up, collimated down more. We're not so focused on the entire knee. But this is why, once again, why you're not really going to ever see these ordered. They're just going to order a regular knee x-ray because it looks almost exactly the same. And they're just going to get more information on that knee x-ray overall. But if they did ask for it, once again, we would center on that popliteal crease, collimate down. We want our patella to be centered to the collimation field because that is the star of the show. That's why we're doing the x-ray. No rotation, optimal exposure factors, and very tight collimation. For this x-ray in particular, the tighter the collimation, the better, because the patella is very hard to visualize against the femur. The tighter that collimation, the more it's going to pop out to you a little better here. And that's what we see represented right here on the surface of the femur. There's our patella. And that would be our PA patella view. Now, the same problem arises whenever we move on to the lateral here. Once again, they're more often just going to opt for what? A lateral knee. Why? Because I see the exact same thing on a lateral knee as I would for a lateral patella. Only difference for the lateral patella is I'm centered directly on the patella itself, not really showing so much the knee. But once again, when you weigh it all together, they're more often just going to go ahead and order a regular knee x-ray. For a mediolateral patella, by the way, that's mediolateral only, mediolateral patella, we're going to put our CR perpendicular to the mid-femoral patellar joint. Now, don't mix that up. There is one difference there. If you remember on the lateral knee, we had a 5 to 7 cephalic angulation of our tube. With the lateral patella, it's a perpendicular beam, no angulation at all. And we are going to put that CR at that mid-femoral patellar joint. Basically, you would palpate the patient's patella in that lateral position, filling for the little space right here, and you put your central ray directly on that joint space. The knee will be slightly flexed 5 to 10 degrees, and the reason we flex that knee 5 to 10 degrees is to put the patella in a true lateral position. So it's going to look almost exactly the same as a lateral knee as far as the x-ray is concerned, which is why I keep saying they're not ever going to order this. They're just going to opt for ordering a lateral knee because it gives you the same exact results, essentially. And as you can see, to the naked eye, it just looks like a lateral knee. We're just a little bit more focused on the patella. So what do we need to see if for some crazy reason they ordered this x-ray? Well, we of course want the patella and knee joint in the center of that collimation field. That's talking about this area right here. And that's not even really centered based on the evaluation criteria. That should be centered a little bit more posterior. And we want that patella to be in a true lateral position so we can clearly see apex versus the base. And of course, we want that nice prominent space in between that surface of the femur and the patella to demonstrate that nice open patellofemoral joint on that x-ray. And that would be our lateral patella. So PA and lateral patella, considered routine, but not really ever ordered anymore these days. They're going to opt for those plain knee x-rays because they show the same thing. Now let's start talking about some of our specialized views. You will see these much more often. Now, even though that set gas method, the sunrise method, is the most common you will see, you'll also see some of these other views we're going to talk about at the clinics you visit. Depending on what clinic you go to, you might see all or some of these because every clinic has their own preferred method they like to use. Now me, once again, I love the set gas method. That's my favorite way to do patella views. And I'll show you which version of the set gas method I find superior. There's two ways to do set gas. But we are going to start with what we call the merchant bilateral method. Now, this is called the merchant bilateral method because we actually use what's called a merchant board. That's what you see the patient sitting on here. This is called a merchant board. It's a wooden plank that's going to put the legs in a flexion of 40 degrees. So we're actually going to sit the patient on this merchant board, and the way that the legs are actually angled, they're going to meet what we call 40-degree angulation of the legs. Our CR is going to be angled 30 degrees towards the patient's feet, And we're going to put our CR basically right in between the knees. And as you can see on the film here, it's going to look like two little bumps coming up. That's the knees or the patella joints that we're looking at. So that's patella and the knee joints that we're looking at on that film. And you'll notice something else. What's something peculiar about this x-ray? It's not centered on the film, right? It's one of those big exceptions where it's allowable to not be centered on your cassette. Why? Because it would not be possible in this position. This would be the best view you could get of those knees on that cassette. So that's why I would say this position right here is not exactly ideal. I definitely prefer set gas because with set gas, you can guarantee centralization on your cassette. You get a much better quality x-ray. Now, why would they opt for this? Well, really the reason they would opt for this view, even though it's going to be lower quality, is they can do what? Comparison view, much like the weight-bearing knees. As you see, they are x-raying both patella and femoral patellar joints at the same time. They're getting the right and the left together. So you'll be able to get that comparison view side by side. So even though the quality is not going to be ideal, if the doctor really wants that comparison view, this would be an option the technologist could do. But not something I would recommend. I would still recommend set gas personally. This is going to be what we call the merchant bilateral method. Keyword bilateral, that tells me I'm looking at both knees, both patella. And it's called merchant because we're using what we call a merchant board. And that's what that looks like a little bit with the patient off of it. There's that merchant board. Patient literally sits on the end of that merchant board, relaxes the legs on that slanted plank, puts those legs in that 40-degree angle. We let our central ray drawer here. Central ray is going to be at a 30-degree angle, going through the patient's knees, which are about right here, and giving us that view of both the patella and the patellofemoral joints opened. And that's what it would look like right there. Not what I would call the prettiest x-ray, but it does get the job done. So if we opted for doing this merchant method, We want to see the intercondylar sulcus and patella visualized. Intercondylar sulcus, by the way, is this surface right here on the femur. It's dipping down. We do want to visualize that. That's the intercondylar sulcus. Patella, of course, is right here. And then we want that joint space to be completely open, which we do visualize on these x-rays. Here's that nice open patellofemoral space. And we can get that nice comparison view because we're doing both of those patella and joints at the same time. Most texts you'll see here at Harris Health will label both sides. So if you're saying, well, am I going to get an x-ray and can I tell what's left versus right? I will make sure if I had a x-ray on your test, it's clearly labeled left versus right because that can get mixed up. It's very vital that you mark the left and right, especially if the tech was to accidentally flip the film. That could obviously cause a lot of issues with the doctor reading those x-rays. They could misread those x-rays if they weren't labeled. It's very essential when you do these bilateral views, you actually label that right versus left and go ahead and put in there, put that you did the merchant method so they know what's going on there. But most of the time they do know because they order those specifically and ask for them to be visualized in that way. So let's go to the one that I like. This is the set gas method. You guys should have learned this in lab. Now this right here is the traditional way you'd see a set, I'm sorry, not traditional. This is the old school way, I would say, that you'd see a set gas done. This is not my preferred way to do it. I believe this is the way you guys were shown in lab. I don't know if you guys were shown the alternative method, but how do we do a set gas method? Well, we're going to put the leg in a direct 90-degree flexion. How do we do that? We want the tib fib to be perpendicular to our plates. It's going to put the leg in a 90-degree angle. It's very important. Otherwise, we're not going to get that separation of the patella from that surface of the femur. Our CR is going to be approximately 15 to 20 degrees angled from the lower leg. That's a range. I usually just stick with the 15, and we're going to put that central ray right at the apex of our patella, right on that joint. Adding that angulation plus flexing my leg at 90 degrees is going to give me a single view of my patella separated from my femur. It's going to demonstrate the patellofemoral joint opened with that patella above the surface of the femur. That's why this is also sometimes called a sunrise view, because the patella should look like the sun going over the horizon. I'll show you on the x-ray what I'm talking about. So you'll see it labeled as sunrise or set gas. The actual technical name, though, is set gas method. This is the way I like to do it. You'll see a lot of techs do it in this fashion. I prefer to have my patient sit on the table with their knee bent, and I will angle my CR accordingly to match up with the patient holding that cassette in front of their, in the back of their knee. I have found this to be the most effective way to get beautiful sunrise films or set gas films. This is an official way to do it. You have the option of doing it this way, right here, the PA method, or the method you see right here. I've just found overall it's much easier when you position your patient like so, and it gives you much prettier sunrise films. So both are considered acceptable and official ways to do set gas, or also called sunrise method patellar views. And this is the one right here, guys, I'm talking about, the set gas method, that you'll most often see paired up with a traditional knee series, because they love doing set gas patellas with knee x-rays to go ahead and get that nice isolated view of the patella separated from the surface of the femur. So look at the integrity of that joint space. Now this film right here is showing you what would happen if you overflex the knee on either of these views. You have to make sure you flex the knee accordingly in the right way. If you overflex your knee, you don't get your sunrise. What are we looking at here? The patella is actually almost touching that femoral surface. We don't want to see that. We want a clear separation of this joint space. I'll show you what a good one looks like here in a second. This tells us that the patient's knee was overflexed. That patella is touching the intercondylar surface, or sulcus rather, or that femoral surface as well. Nice, clear space between that patella and femur. Now, this is the other way you'll see it done in a lot of clinics you go to, guys. This is what we call the Hobbs method. I believe a lot of the clinics like CASA and other names are escaping me, but a lot of the clinics you guys are going to visit like doing this Hobbs method. It's another method that we do, guys, if they want to do a comparison view of the knee joints, comparison view of the patellas. It's going to look a lot like the views we just looked at. We're going to be, thank you, Valbona, that's another one. Smith is another one. I don't know why those names were escaping me. But this is going to give you a nice comparison view of those open joints. Now, basically, the patient is going to sit in a chair, like you see right here, with the knees bent. We're going to be using a perpendicular central ray going at the film, which the film is put on the floor or on a little stool. We want our central ray to go right between those knees that are bent, and that's going to give us a nice view of those open knee joints. These are only flexed slightly. The SID is going to vary from 48 to 50 inches. This is another method I don't prefer doing. I still prefer sticking with the set gas sunrise methods that we just went over, because overall I feel like they give you very superior films, but you might be asked to do this particular method. Once again, the Hobbs method, also called superior inferior sitting tangential, if the doctor wants a comparison view. So I would say more often than not, when a doctor wants a comparison view of the patella and knee joints, they would opt more for the Hobbs method versus the Merchant method. And the reason for that is the Hobbs method is going to give you a little bit higher quality, because in comparison to that Merchant view, with the Hobbs method, we can actually get that centralization on the cassette, which that centralization on the cassette, once again, is going to give you superior quality on those films. And that's what a Hobbs would look like right there. Now, if you look at that in comparison to that Merchant method, that's much, much, much better in quality. And that's what we want to see. We want the patella clearly separated from the femur, with that patellofemoral joint space clearly opens. And we want both of those patellas side by side with a left and right marker to designate. And I would suggest, once again, if you do Hobbs method, we'd put Hobbs method up here in the corner, just to let the doctor know what exactly you did. So once again, not my preferred method, but if they do call for those bilateral patella, this would be the superior method compared to the Merchant method.
Mr. Donahue, if we were to test out in clinic, and let's say we're more comfortable with the clinic method, do we still have to do what we learn in the lab, or can we do the clinic?
You can do the clinic method. So let's say you go out to a clinic and they're using this Hobbs method right here. That would still be acceptable. You would pass it as long as you have to do what their protocol is. And some of those clinics, their protocol is the Hobbs method. You wouldn't do the set gas method. So whatever they're calling for with what they're using, and that would still be acceptable for competency, yes.
Okay, thank you.
Welcome. And with that, we come to the end of the lower extremity chapter. A lot of information in this chapter, guys. A lot of information. In fact, you probably feel like it's an information overload. Probably one of the heaviest chapters we've hit so far. A lot of stuff. A lot of stuff. So, hang on a second here. So, I did not have time to come up with the practice test we usually do on quizzes, guys, but never fear, I'm still going to make that for you. So, your lecture exam is going to be on Monday. I'm going to get you that practice test by Friday, so it's something you can review over the weekend while you're studying all this information. I'm going to give you a very extensive practice test to go over on that. So stay tuned for that. Image review test is still going to be on Friday. It's going to be the same format we've done before. We're looking at 4 images. I am kind of rethinking how we go about this image review. I'll share that with you on the day of. I might change it up just a little bit to make sure everyone has ample time to label that anatomy. Because probably the biggest critique I've had is you feel like you don't have enough time to get through and label that anatomy. So I'm definitely rethinking that a little bit. Yes, the positions on the practice images, I'm going to pull that up in a second. Any questions on the chapter material so far? I know it's a lot. I'm sure you'll have questions as we get closer to the test. You can always shoot those my way. But any questions right now that I can answer for you? Can I hide the timer on the image review? Is it distracting to you? I am rethinking how we do that. Don't worry, I'm looking into that. Okay, if you have any questions, let me know. I'm going to go ahead and pull up the practice images real quick to make sure you guys have all the correct positions on that. If there's any questions specifically I can answer, I'll definitely do that. Just a second. Wrong class. Bear with me, guys. I seem to have lost the document. Just find it in my email here. There we go. Oh. All right, there we go. I'm pulling it up here. Okay. All right, so for our first couple of images here, I'll show you guys a study tactic here as well. Let's name these positions first. These first two images that we see right here are both going to be AP feet, AP foot for both of these. Over to the right is a lateral foot. Scrolling down, we have a medial oblique foot. So on the direct left here, medial oblique foot. In the middle here is an AP ankle. On the right here, we have a Mortise view ankle, Mortise view oblique ankle. Scroll down here, we have a very badly positioned lateral ankle. Anyone tell me why this is badly positioned? One of my biggest pet peeves.
It's not dorsiflexed.
It's not dorsiflex at all. It's just a limp foot. You never want to do it like that. Dorsiflex that foot. It's a lateral ankle. To the right of our lateral ankle, we have an AP tib fib, or AP lower leg is also another way you can write that. AP tib fib or AP lower leg. Below that, we have a lateral tib fib or lateral lower leg. And to the right of that, we have an AP knee. This is another AP knee. And right next to that with all the drawings is also an AP knee. Then we have our lateral knee. This is a great one to focus on right here. This is a little bit what we talked about today, guys. This is a lateral oblique knee. I want you to look at that really closely. How do I know this is a lateral oblique knee? Look where my patella is. It's on the side of the fibula, which tells me that's lateral oblique. Also, if I look at the fibula and the fibula is superimposed on the tibia. It's another indication that I'm looking at a lateral oblique knee. Versus, what do we think this is? That's a medial oblique knee. How do I know that? My patella is on the side of the tibia, and I also have a very open proximal tibiofibular joint. That's a medial oblique knee. Right here on the right, we have a set-gast or sunrise view patella. You can use either one of those terms, set-gast or sunrise view patella.
Mr. Donahue, going back to the medial oblique knee, how do we know which one's left and which one's right? Because that one doesn't have a marker.
I will make sure there's a marker. If not, I'll tell you which one it is.
Thank you.
You're welcome. Then down here we have the axial calcaneus. Dorsal axial calcaneus.
Can you repeat it again? I'm sorry.
Plantodorsal axial calcaneus. And this last one, guys, that's what we talked about a little bit a while ago. What am I looking at? A very prominent intercondylar fossa. Therefore, I can label this as intercondylar fossa view, Camp-Coventry, Palmblad, or AP axial intercondylar fossa. Either of those terms I just read off to you would be acceptable. I'll say it again. Intercondylar fossa view, Camp-Coventry, Palmblad, or AP axial intercondylar fossa view.
Can you go back to the patella one? I didn't quite catch that name.
Right here?
Yes.
The sunrise or set-gast view of the patella. Sunrise or set-gast patella.
Mr. Donahue,
Uh-huh.
so for the sunrise view, how can I know it's medial condyle and lateral condyle?
So if I have a set-gast view like we're looking at right here, and my right marker is present. If my right marker is here, the lateral condyle is on the side of the right marker. So in a right view, the lateral condyle is on the left, the medial condyle is on the right. If this was a left, it's going to reverse. If this was a left set-gast, my medial condyle is on the left, lateral condyle on the right. So it would reverse. Yes. Now, what's something you can do to study, guys? This is what I do when I'm studying anatomy. This may work for you, it may not. But if you go into Microsoft Word, you go up here to Insert. There's a little option that says Shapes. Click on Shapes and hit the rectangle button here. I will always go through and add little rectangles to cover up the anatomy. I'll just copy and paste them all over and cover up what I'm looking at. And as I'm studying, I'll roll off the top of my head what I know. And I can quiz myself like this. I'll click on the box that say, what's it pointing to? What's it pointing to? Is it tibia? Hit delete. I check my answer. It's tibia. Then I can hit undo to put the box back. That's something I suggest to you when you're studying anatomy. Don't just look at the words. Cover up the anatomy and see how much you know. That way you know what to go back and focus on if you miss that particular anatomy. It's a great way to study that. It's always worked well for me. It's something I definitely suggest. Cover it all up and see what you know. That way you can go back and focus on the anatomy you're having trouble with, and you're not overwhelmed with all the tons of anatomy hitting at the same time. You're not overloading your brain. But on the test on Friday, it will be 4 images, just like we've been doing so far. Probably add a bonus in there as well. I'm thinking of a bonus question already on the top of my head. Any questions as far as what to expect on Friday or what to expect on Monday?
Mr. Donahue, could you repeat for me how can I know if it's medial oblique knee or lateral?
Sure. So let's look right here to this first picture, Wani. So this is a lateral oblique knee. How do I know that? I look at the patella. Patella is rotated towards the side that the fibula is on. Here's our fibula. Fibula is on the lateral side of the leg. Therefore, that tells me I am rotating that knee in the lateral direction. I also look at the fibula superimposed upon the tibia. That's another indication that I am looking at a lateral oblique knee. Let's look in comparison to the medial right here. On a medial oblique knee, I look at my patella once again. I noticed my patella is now on the side of the tibia. Tibia is always on the medial aspect of the leg. Therefore, that's the first indication I'm looking at a medial oblique knee. What else do I look for? I look at my proximal tibiofibular joint right here. It's very open. That's the second indication I'm looking at a medial oblique knee. Go back up once again. On the lateral, tib-fib superimposed. On the medial, they're separate with that joint opens. Lateral, once again, patella is on the side of the fibula. Medial, patella is on the side of the tibia. Making sense? All right. Yes, though the Play-Doh experiments. Well, I was going to leave that as a surprise, but since you're so nicely asked. So I had a lot of trouble, guys, coming up with a winner on that because you guys did really well. And I decided to be nice because I know you guys are really stressed out. This is a tough chapter that I'm giving everyone +2 on your exam. And the reason for that is because you guys have been a really good sport. You guys have been very patient despite the circumstances we're having to do all this. You've all been participating well, which I really appreciate. And that's a thanks from me to you for being team players and getting through this crazy semester that we're going through with all this COVID stuff. So thank you guys for participating. Great job on that. You made that actually very hard on me to decide. So everyone's going to get +2 on their multiple choice exam on Monday. So good job. Good job. We got one more to go. The next one's going to be the hardest one. But we'll get to that in the next chapter. All right, guys, is there anything else I can do for you or answer for you before we wrap this up today? All right, guys, well, as you're studying for the anatomy on Friday and, of course, the test on Monday, please let me know if I can help you in any way. If you need any extra help, clarification, send me a text, give me a call. However you want to communicate with me, I'll be glad to answer it for you. With that being said, we're going to dismiss for the day. Go enjoy your extra time off you have today. Start studying, but don't overwhelm yourself. Use your time wisely. I'm about to actually head up to Kirby right now because I got to get things set up for your practicums this coming couple weeks. Don't forget, those of you that are scheduled for tomorrow, I will see you at 1 o'clock to do your practicums. Looking forward to it. And everyone have a wonderful day. And I will see you all very soon. I'll send you the rest of the PowerPoint, by the way. Have a good one, guys.